It is an honor to be with you. Thank you very much for your invitation. Long trip. I hope that maybe I don't jet lag on you, and I apologize if I do. Very well. I have two presentations. The first one that I will be discussing in the following 15 minutes will refer to prostate carcinoma and the metastatic hormonal sensitive, a situation that until a short while ago our only treatment was hormonal ablation. I want to begin with the end, the outcomes, the conclusions, or the photograph that you can take home. We have two new treatments to apply in hormonosensitive metastatic cancer. One is abiraterone, and the other is docetaxel. In this meta-analysis of different trials, when we apply the first drug, we reduce the risk of death 38%, and when we apply docetaxel, we have two positive trials and that show a 23% reduction of death in the risk of death. These are two new treatments that we would need to apply when hormonosensitive patients. And now what I will discuss is in all patients or in all selected patients, and which ones would benefit the most from these treatments. Something else that we have learned in prostate cancer that is hormonosensitive is is that not all metastatic patients are the same. We began to establish certain terms, a low tumor load, low risk, and low volume. We begin to classify patients in groups, and not only that, but we've also been applying terms such as oligometastases and multiple metastases. Every one of them needs to follow a potentially different treatment from the systemic perspective as well as from the local perspective. Let's review each one of these points. We will begin with oligometastatic disease. This is a paper that was published this year, 2018. I think it's a Dutch radiologist, but it looked at a group of patients with metastatic prostate cancer and defines oligometastasis as 3 or less lesions. And this is an issue that we're going to discuss. Our techniques are become obsolete, and as we apply new techniques, in this case, the inclusion criteria was 3 or less lesions and hormonosensitive patients. And the author randomized between radiotherapy of these 3 lesions versus non-treatment to determine how much we can delay androgenic treatment. And with the specific treatment of the 3 metastases, he can delay androgenic treatment significantly versus the control group that had not received any kind of treatment. Most often, treatment initiated with a higher PSA. And more than 60% of patients 3 years after had not had to start androgenic treatment. So very few patients and a small study, but it's suggesting that treating metastasis has an interaction in the systemic evolution of the disease. This other study was presented in 2018, very few weeks ago, and it is the outcome of comparing metastatic patients with newly detected prostate cancer with a systemic treatment versus systemic treatment plus radiotherapy of the prostatic tumor, even though it is metastatic. And this study will be repeated throughout the morning. This is a study done by British colleagues and also involved a Swedish institute. The purpose of this study is that they wanted more than half of the patients with prostate cancer to be included into clinical trials, and they designed this trial. All patients who went to a radiotherapy, urologic, or oncologic clinic would be candidate to a systemic treatment and in the upper column, that is a reference treatment. So the authors designed new branches comparing the reference treatment, which was hormonal block. We'll talk about the different branches of docetaxel and some of the branches that were negative. So one of the branches we see here, which is H, included comparing standard treatment, hormonal blocks plus docetaxel, because they had changed the reference treatment and compared that reference treatment with local radiotherapy treatment plus systemic treatment. I would like to insist that these are not only metastatic patients, there are some monorefractory patients. And the study was specifically geared towards the metastatic group, however. This is what I was explaining before, standard treatment versus standard treatment plus local radiotherapy. Outcomes in terms of failure-free survival. Well, here we have the radiotherapy group has a longer failure-free survival. Many of these progressions are biochemical. When we analyze survival, at least with the follow-up we have, 2,000 patients, the figures are spectacular. There are no survival differences of notice. So we gained time controlling symptoms without any survival repercussions on survival. But when the author analyzed the same survival by subgroups and analyzed it according to the tumor load, in the subgroup with low burden, there is a scant difference in survival with radiotherapy. So the metastatic burden plus, so clearly, this study suggests that if we have a patient with a low tumor burden and the low metastasis volume, then in addition to systemic control, we should control the local disease in some way. In this case, with the radiotherapy. Speaking about oligometastasis, the treatment needs to be different regarding the rest of the. Let's look at the presentation. When we are dealing with oligometastasis, and we will briefly discuss docetaxel and abiraterone in combination with hormonal therapy. Once again, initially one of the control branches in this STAMPEDE trial was docetaxel plus hormonal block, and the other one is abiraterone. And we will analyze what happens when we compare these two branches. In this case, in this metastatic study, has included high-risk patients. The results in the survival for all patients, there's a benefit in adding docetaxel, and in the right curve, in this, we have the specific subgroup of metastases. When we show means of small differences here, the difference is more than 1 year adding docetaxel in patient with prostate cancer, metastatic prostate cancer. Another trial, the charted trial, was analyzed for patients with high volume and to look at the effect of docetaxel. This trial is old, and they tried to identify or run the trial with patients with high volume, and they included patients that had a new metastasis or patients that developed metastasis throughout the trial period, and at the end, they included some patients with low volume. And the concept of volume applied to this trial is that patients who had more than 4 lesions, the results, again, there is a difference in survival when we add docetaxel to the hormonal treatment. These are the additional data for 2018. Red, I have underscored the curves of patients with low volume. In these curves, we are including the patients. Low volume. Patients with new metastases, the curve on the right. No, I'm sorry, the curve on the bottom. And total patients on the left. None of the curves, when we add docetaxel in low volume, and none of the curves in this trial show statistically significant differences. The curves that represent the total patients and patients who develop metastases during the follow-up, and all three curves adding docetaxel with high volume provides a benefit to patients when we use androgenic block alone. So we should constrain these results to high-volume patients. I also want to underscore that the subgroup of patients with metastases that are developed in the follow-up, we have a smaller difference. And the difference here is more clinical. And we will look at this may be due to a different biology. So patients with docetaxel is more constrained to high-volume patients. Let's look at the results with abiraterone. Let's look at the STAMPEDE trial. Let's begin with Latitude. Latitude is a trial in which we follow the same design. We compare hormonal blockage and hormonal blockage plus abiraterone, and high risk are defined to my right. Patients who have 2 or more lesions and characteristic metastases or bilateral metastasis. The goal was survival, and here we only included patients who had new metastases. Once again, the new publication in New England a couple of years ago, in terms of global survival and progression-free survival, here the differences are of about a year and a half between abiraterone and only hormonal block and placebo. And we are comparing the risk of developing metastasis or death. When we look at time to biochemical progression, when we do hormonal block in high-volume patients, the time to progression is only 7.4 months. These are patients who are truly where hormone block is insufficient as treatment. Other characteristics that I wanted to underscore for chemotherapy and other treatments, but this also has repercussions in life quality. This is the analysis of life quality data. Abiraterone, there is a slower decrease in life quality than the branch with placebo only, and the same results in pain. This is the update of the results from the past ASCO, and with longer follow-up, we maintain the branch of abiraterone, and it continues to be above the placebo branch, and the difference is very significant between both branches. Let's look at STAMPEDE. STAMPEDE, they also added the branch with abiraterone that was compared with androgen deprivation, including all the patients, and all patients means those that are locally advanced or metastatic. The curves on my right, benefit in overall survival. Once again, metastatic patients and non-metastatic, we don't see a difference in survival, but we do see a difference in survival free of progression. Once again, I would like to repeat that we saw smaller differences among patients non-metastatic on no non-metastatic patients. Finally, these are the outcomes, and the patients are stratified by patients or by volume. These are the patients with high volume. In those patients, they stratified them according to the charter characteristics and also the characteristics of the Latitude trial. High volume, as we confirmed in the Latitude study, received benefit. Then low volume in the STAMPEDE study to see what happened when you added abiraterone. These patients hadn't been included in the Latitude trial, and we see time to biochemical progression, and again confirms that adding abiraterone in low volume patients, we obtain a benefit in survival. The curve to the right, there is a benefit in favor of the abiraterone. So it's not just survival, not only time to progression, and in low volume, as we saw, there's a benefit in low-volume patients that hadn't been proven with docetaxel. So what do we need to use, abi or docetaxel? I would like to insist these are purely medical criteria. There is an economic factor that, of course, we cannot overlook, and that needs to be considered in each specific situation. But let's look at the medical criteria. What are the differences between one and the other? Well, in the Stampede trial, we see that there's a moment in which we included patients for the ABI branch and for the docetaxel trial, but they are statistically non-comparable, but an indirect comparison has been done between both branches. In terms of failure-free survival, abiraterone showed better results or outcomes. This is biochemical progression, is produced earlier. If these differences occur in the metastatic and the other group. When we look at survival, nevertheless, the branches are very similar in metastatic progression-free survival. But there are no differences of note. There were differences when we analyzed toxicity. Abiraterone is not an atoxic treatment. 99% of the patients referred some kind of problem, but the severity of the toxicity can be greater in the docetaxel branch versus the abiraterone. We need to growth factor febrile neutropenia with ABI. And this is a point again versus docetaxel and death due to the drug, because this is a drug that is not for all patients in Spain. When we analyzed refractory patients, less than half ended up with docetaxel because these are trial patients that received a lower level of toxicity and the potential for mortality with at 1% docetaxel. Meta-analysis, indirect meta-analysis comparing both drugs, it suggests that ABI could provide certain benefit greater than the docetaxel branches. Suggestions or guides from our U.S. colleagues, whether docetaxel or ABI. I believe this article was published last year, and they suggest what we have been repeating throughout this presentation. The data are few. In patients that develop metastasis during follow-up, maybe they have a different kind of biology, and for those patients who are good candidates for docetaxel with low risk of toxicity equivalent to abiraterone, and considering economic factors, something we haven't discussed is we have compared one branch to the other, but we haven't compared early or later treatment that would have decreased maybe the great differences that we have seen between both drugs. So standard of care for hormonosensitive metastatic patient was docetaxel and ABI. And the low-risk group, we were using docetaxel with the results that we have seen before, with negative results published for docetaxel in low-risk group or oligometastatic group. And ABI, for that group, we might need to use abiraterone and not use docetaxel and use primary radiotherapy in selected patients. Those that have been initially treated with a localized treatment and have developed metastasis and they're low risk, well, maybe they have a different biology. And if we might need to add, for example, androgen deprivation, and that would be enough. But if they have a local and high risk, the question here is difficult. These patients were included in the Stampede trial. They were included partially in the charter, and there the outcomes were beneficial. But maybe The question is whether or not to add a systemic treatment in these patients. Finally, I wanted to end with this last slide that will give us a little bit of information. And this is the PEACE-1 trial that is on the verge of ending its recruitment in Europe. We have been including patients. They compared androgen deprivation with androgen deprivation plus abiraterone and or androgen deprivation plus local radiotherapy. We had 4 branches with the results of docetaxel led us to modify our protocol. So we have androgen deprivation plus docetaxel, and this 2 branches there, local radiotherapy using abiraterone in 1 branch and the other one with docetaxel. So here we have all treatments. So we will obtain the answer and determine if some patients benefit from all treatments at the same time. So we are just concluding the recruitment, but it will take time to obtain the information we require, but it will certainly be of interest. We should not forget cost and the arrival of new therapies. We are using increasingly new treatments and codeines and new diagnostic methods that will perhaps modify the concept of oligometastasis. Okay, they erased the slide with the waterfalls, but that was my thank you slide. Thank you very much for your